we'll go ahead and get started. I mean, if we can stay ahead of the curve here, that would be amazing. So, uh, I don't know that you two need too much of an introduction. I think everybody knows you all by now, but Dr. Sid and Zoe from Boston Children's Hospital and working with the Kleefstra Clinic, and we've had a great 5-year relationship, and so looking forward to many, many more years, and excited for this because this is all what we want to do when we're talking about things internally and with our partners throughout the world. It's all about getting clinical trial ready. That is the dream. Is positioning ourselves to the point where when a treatment comes along, our community is built and structured where we don't have to then stop and do this work, that we could be doing this work in parallel so that hopefully everything aligns really seamlessly. And Eric, I don't know if you have anything to add there before we get started, but I'll turn it over to the rest of you all.
Jeff, I think you nailed it, and I'm not going to delay the presentation any longer.
Awesome.
Awesome.
Well, thank you guys.
Sounds great. Thank you for the introduction, Jeff and Eric. It's lovely to present to everyone today. My name is Zoe Frazier. I'm the genetic counselor that works in the Kleefstra program at Boston Children's Hospital. And I'll be co-presenting today with Dr. Sid Srivastava, also known as Dr. Sid, who is the director of the Kleefstra program here at Boston Children's. And today we'll be presenting a talk called The Roadmap for Clinical Trial Readiness for Kleefstra Syndrome. And the goal of this talk is to outline the various studies that we've conducted at Boston Children's and talk about how these studies are helping us build towards this goal of being clinical trial ready. Okay, so I'd like to start out by showing this rare research roadmap, which some people may have seen before at other rare condition conferences. But this really depicts the road that many rare condition groups are on as we work towards this big end goal of finding a drug that targets the condition in question and treats it. As you can see, this is not a linear path. It's very circuitous. There's lots of different hills and valleys. And I wish it was as simple as we've identified a condition, we'd like to treat it, now we have a treatment. But in reality, there's lots of different paths and routes. There are some setbacks that we can encounter, but also really large gains. And right now, in the Kleefstra world, we're really working towards getting to this point, this clinical trial ready point, where we've laid the groundwork scientifically and have developed a drug that we think can treat Kleefstra syndrome. And now it's time to test its safety and efficacy, test dosage. So although this is a long path, we are all, families, clinicians, researchers, we're all in this little bus together. And Kleefstra syndrome, we're not at the very beginning of this path. Over the past 5 years, and even before with Dr. Kleefstra's research, the foot has been on the gas. So we're trying to shoot our way down this highway to eventually get to clinical trial readiness and then finally get to a developed drug. So when thinking about research readiness, there are 4 primary categories that must be in place and kind of 4 different pillars. So first of all, when it comes to the biology of the condition, we really have to understand that. We have to know what gene or genes causes this condition. Do we have a cell model or an animal model that has these genetic changes that we can do experiments with? We have to be therapeutically ready. We need to know what the therapeutic window is. What is the prime age or prime stage of the condition for treatment? Do we know the safety of this potential drug that we would be developing? We need to be clinically ready for a clinical trial. So we need to have endpoints and biomarkers, and these are measurable condition-specific features that, if we do administer this therapy, we need to be able to measure change and really track whether or not a therapy is making a positive or the desired effect. And equally, if not the most important pillar of research readiness, is you need an engaged patient population. These other 3 pillars can be in place. We can have all the data we want, but if we don't have an engaged patient community, it means nothing. So once again, we really need families that are engaged in the community, fill out the surveys that they receive, participate in research in any way they can, lend their perspectives, collaborate with researchers and physicians. So we really need all 4 of these to be in place to be ready for research. And at Boston Children's, we've been really fortunate to form a partnership with iDefine. As Jeff mentioned, this has been going on for 5 years. So in 2020, before this marker of 2021, they were in touch with our group at Boston Children's. Dr. Sid started seeing patients in neurology, and then in 2021, the Kleefstra program within the Rosamond Stone-Zander Translational Neuroscience Center was established, and this was the formation of a formal clinic, and then also the research arm for this program. And since then, we've worked really closely with iDefine for family conferences like this, scientific conferences, international collaborative meetings with researchers from all over the world. They've helped us with developing research protocols, expand our clinic. So we've had a really important partnership with iDefine. And now in 2025, we've seen 111 patients with Kleefstra syndrome. And these are unique patients, not just patients that we've seen repeatedly. So we provide continuing care to 111 patients. But we've also enrolled over 70 individuals in research. And so the Kleefstra program resides, as I mentioned, within our department called the Rosamond Stone-Zander Translational Neuroscience Center. And it's a department within the neurology department at Boston Children's, where we have a list of various rare conditions that then physicians see clinically, but then those physicians are also the PIs that lead translational research for that condition in question. So, for example, in the Kleefstra program, we see patients clinically, and our goal is to evaluate these patients that have Kleefstra syndrome and create patient-specific plans for each individual to really optimize their potential. Any patient that's seen in clinic can then, depending on the study and the enrollment criteria, can enroll in the research, whatever research we have going on at Children's in this program. And our research really aims to better understand Kleefstra syndrome from a wide variety of perspectives, with the ultimate goal of being clinical trial ready. Anything that we find out in research, then, whether or not families enroll in research, feeds back and benefits. It provides information to our clinical patients as well. So our clinic patients either enroll or provide really important perspectives that inform our research, and then in turn, any research results then feed back. So it's this positive feedback loop between clinic and research. These are the members of the Kleefstra research program. So some of these faces may be familiar, but we have Drs. Sid Srivastava, Maya Chopra, Jonathan Lipton, Joe Kozowski, and Chari Bairaktutan. They're all physicians that have either been PIs or implemented different research protocols. That's myself. And then Meg Quinn is our clinical research assistant. And then we also, to highlight the other half of the program, the clinical team, as you recognize, it's also Dr. Sid. He's a pediatric neurologist, so he sees patients clinically as well. We have Dr. Ann O'Donnell-Luria, who's a geneticist. And then we have a new genetic counselor named Jill O'Toole, who has just started seeing patients with Dr. Sid. And then we have a variety of clinical partners in various specialties, depending on your child's needs. And then Bryn Heslin is our new genetic counseling assistant who helps with intakes, onboarding, scheduling, and making sure that families are onboarded properly. So over the past few years, we've been involved in several different types of research protocols here at Children's. As I mentioned before, to date, over 70 individuals have enrolled. Our past research, as you just heard, so we were involved in the natural history study for ages 13 or older, and Yost just presented those results. That was really exciting to see that presentation. Results coming soon. We were also involved in the disease concept model for which those results are available. And currently we have 2 research protocols going on. One is close to enrollment, but it's the circadian biology of EHMT1. We're trying to better understand sleep in the context of Kleefstra syndrome and whether or not that is, associated with the regressions that we see. And then currently enrolling, we have a natural history study called the Action Initiative that is meant to be a complementary study to this natural history study that Joost and Dr. Kleefstra led. So currently we're enrolling, and we'll provide more information later about that study. But for the purposes of this presentation, I'm going to focus on the current research that we have going on here. So this is a depiction, this is an image of our building. So we see patients on 1, 2, 3, the third floor right here. And then we also see patients up here in various different rooms. But this is, our clinic and our research is all housed in the same facility in Boston. And this is just an image of, the waiting room and our facilities here. As I mentioned, to date, we've seen 111 patients with Kleefstra syndrome. And you're probably asking yourself, why is she talking about clinic so much when this is a research presentation? And I'm highlighting this because even if a family is unable to contribute to research directly, by coming to clinic, we learn so much from each child. We're able to look at our patient cohort in aggregate and look for clinical features that are prevalent and try and better understand, what are good treatment options? Are there any genotype, phenotype correlations? For example, is a person's genetic change associated with certain Kleefstra-specific traits? So this exact research goal, these research questions, led to our initial paper where we published the first 65 patients in aggregate. So I know I said we have 111 patients, but this was published earlier this year, and it took about 9 months to put together and have a paper accept everything. It's a long process. So this speaks to the fact that we had to call it at a certain number, and also we've been trying to see as many people as possible. But this was just the initial publication of our first 65 patients. And we looked to see if there were any novel features that we saw within our patient population and any of those genotype-phenotype correlations that I just talked about. So within the first 65 patients that we evaluated, this shows the demographics. So as you can see, most of the people that we saw in clinic are children, so younger than 16. Although we do see, we had seen up to that point more adults, and we continue to see anyone across the age spectrum. The majority of the patients in this initial analysis were female. And this shows the breakdown of the type of genetic change that the first 65 patients had. So a little more than half had sequence variants or these intragenic variants, so small spelling changes within the EHMT1 gene. And of the 54%, this is just the breakdown of the type of spelling change that these patients had. And then the other, a little less than 0.5%, had chromosomal deletions. So in gray, these are the smaller chromosomal deletions that we saw. And then the 17% are the much larger chromosomal deletions. And these include EHMT1 and often many other genes around it. This slide shows the neurodevelopmental features that we saw in this cohort. You see a high prevalence of global developmental delay and intellectual disability, as well as, a lower rate but significant rate of autism, ADHD, some communication or speech disorders. And this is fairly consistent with data that's been previously published by other groups. We did look to see if there was some phenotype, genotype trends or correlations. So we compared the features to see if there's anything significantly different in individuals that have the large chromosomal deletions or any chromosomal deletion and those who had those spelling changes within the gene. So when thinking about individuals that had chromosomal deletions, we saw a significantly higher rate of intellectual disability or global developmental delay, epilepsy, cardiac or structural cardiac defects. So these are congenital, something you're born with, significant motor impairment, and then cortical visual impairment. In the intragenic or the sequence variant EHMT1 variants, we saw a significantly higher rate of ADHD or ability to walk independently. And these are the statistically significant differences, but we compared just a huge laundry list of features, and we didn't see otherwise a very striking difference in features between these two genotype groups. And also of note, we get a lot of questions about regression and whether or not someone who has a large chromosomal deletion or intragenic variant is at an increased risk to have regression. We compared the groups, and we didn't see a statistically significant difference of regression between these two groups. Oops. Another genotype-phenotype correlation that we looked at is shown in this figure. So above in this section, this shows the very end of chromosome 9 and all of the genes that are included in that region. In this highlighted gray region here is the EHMT1 gene. Below are all of the chromosomal deletions that we had in this cohort of 65 patients. So you can see it varied greatly in size. So we had some people that had really, really large deletions, and then some people that had teeny tiny deletions. And then we looked at the size of deletion, and we tried to see if there was any significant features that seemed to be closely related to the size of the deletion. And one thing that we noticed is that there seemed to be a significant correlation between the age of walking and the number of these other genes that were deleted. So individuals that had much larger deletions had a lower rate of walking independently or had a later onset in walking. And you can see black means that they're non-ambulatory, they're not walking, and green indicates they are walking, but the shade of green shows that there's a different age of onset when they did start walking independently. This shows another genotype-phenotype correlation, which I discussed 2 slides ago, but it just shows here that individuals that had these sequence variants, these intragenic variants, tended to be less affected from a global development and intellectual disability standpoint than those with small or large deletions. Oops. So in this paper and in our clinic, regression is a really, important topic that we talk about a lot in clinic. And we typically define regression as a loss of previously acquired and consistently held developmental skills. And so when we looked at regression in the first 65 patients, we noticed that there was a rate of about 11% of individuals that had regression. There was also a few individuals, about 3%, who also had catatonia along with regression. We think this is a little bit of an understatement or, an underestimate, but not too far off. And then so our numbers are relatively consistent with another larger research effort led by Dr. Angela Morgan. She's a speech and language pathologist in Australia, and her team evaluated the phenotype of 103 individuals with Kleefstra syndrome, and they noted about a rate of 14% that had regression based on questionnaire responses. We also anecdotally hear a lot in clinic about sleep and disrupted sleep and abnormal sleep, also sometimes paired with the onset of regression in puberty. So we did take time to look at the rate of abnormal sleep in our cohort, and we noted about a 20% rate of obstructive sleep apnea and a little less than 10% rate of disrupted sleep that was reported. And this is an underestimate, or this is a lower rate compared to what Dr. Morgan's team noted, because in addition to looking at speech and language, they also looked at sleep features. And over 60% of their cohort noted sleep disturbances that were not related to sleep apnea. So difficulties with frequent waking, early waking, having a difficult time with sleep onset, and whatnot.
Thank you, Zoe. That was fantastic. I think all this data mentions this really has pointed to this kind of really interesting observation in that fact that with Kleefstra syndrome, one of the things that I've been struck by is the notion that there's this underlying genetic defect that's associated with regression, that's associated with disrupted sleep. But what's the relationship between all of these different factors? How is one leading to the other? Are they related? Are they not? And I think that's one of the fundamental questions that we have yet to answer. Next slide. And so on the way to answering this question, I wanted to just talk about some of our journeys to this point. So I mentioned Dr. Jonathan Lipton, who's a chronobiologist, a sleep neurologist who's focused on, who's been collaborating with us on Kleefstra syndrome. And we started talking about Kleefstra syndrome a couple years ago, and he became really interested in the condition. And since then, his lab has done some really interesting work about the role of EHMT1, the underlying genetic defect in regulating the amplitude of circadian rhythm. Think of circadian rhythm as reflecting the robustness of your internal biological clock. And this is something that affects basically the regularity of many, many fundamental biological processes, including glucose metabolism, including a multitude of other sort of processes. Next slide. And at the same time, we were able to connect with Joe Kosowski, who Zoe mentioned, who's an expert in biometric recordings from humans. And his lab has used various devices, including Fitbit devices, to look at things like sleep staging, heart rate activity, physical activity. Next slide. So it made sense for all of us to partner together. And what we wanted to do is we had this vision of creating this translational pipeline for circadian rhythm and sleep disruption. And we wanted to use Kleefstra syndrome as a model of this. So we decided to build a paradigm involving neurodevelopmental assessments combined with biometric assessments of sleep using Fitbit data, combined with modeling of the biology of EHMT1 on a basic science level to see how do all of these various pieces work together to impact sleep and impact neurodevelopment in Kleefstra syndrome. Next slide. So more specifically, we've been collecting behavioral data, including repetitive behavior scale, which is a repetitive behavior measure. We've been collecting data on the aberrant behavior checklist, which looks at a variety of different challenging behaviors. We've been collecting data on adaptive skills using an instrument called the Vineland, communication skills using an instrument called the Orca. We've been collecting sleep data using standardized surveys, specifically an instrument called the Modified Simons-Separaga Sleep Questionnaire. And in this protocol that we've developed, individuals have been wearing Fitbit devices over a 1 to 2 week period. And some of these individuals, we've even collected some skin fibroblasts, so skin biopsies, to do basic science work. Next slide. We've this protocol is closed for enrollment, but we've enrolled 50 participants in this study, and about half female, half male. Most of these participants are around, actually, I said not most, but rather about half are under the age of 10. Next slide. In terms of breakdown of genetics, 64% have an intragenic variant, 25% have a small deletion under 1 megabase pair, and 10% have a larger deletion over 1 megabase pair. Next slide. And this is a slide that looks at the number of individuals who completed survey data, completed Fitbit data, and that number is over 35 participants. So we have quite a good amount of data so far from those who've participated and enrolled. And we've done skin biopsies in 13 participants along with sex-matched biological controls. Next slide. So I wanted to show you some of the neurobehavioral data first, starting with the Vineland, which is an instrument that looks at self-help skills and covers domains of communication, daily living skills, socialization skills, as well as an overall adaptive behavior score. It has a standard, the Vineland is normalized such that it has a standard score. It's a standard score, so the mean is 100 and one standard deviation is 15. Next slide. So here are scores for the overall cohort. And what you can see across the board is that there's fairly significant adaptive skills deficit. Again, the mean is 100. So these average scores are in the 60s for our cohort. Next slide. So we wanted to compare adaptive functioning by genotype, that is small deletions, large deletions, and sequence variants. And what this slide basically shows is that there's no major differences in the adaptive functioning by genotype when we look at the Vineland-3 scores. But keep in mind that we haven't analyzed all the data yet, and the number of individuals who have data for this slide is relatively small. So that this interpretation may change as we complete our data collection and analysis. Next slide. So we also looked at the repetitive behavior scale revise, which has a number of different items that covers domains of stereotype motor behaviors, ritualistic behaviors, self-injurious behaviors, compulsive behaviors, restricted interest, and also generates a total score. Next slide. And on this instrument, the RBSR, the repetitive behaviors were particularly impactful in the areas of stereotypies and in the areas of ritualistic behaviors. Compulsive behaviors, interesting, were the least reported in our cohort. Next slide. I realize it's probably helpful to try to compare these RBSR scores against comparator groups. So here are RBSR scores from our Kleefstra cohort, which is in blue, compared to repetitive behavior scores from an idiopathic autism group, which is in gray. The opposite. Our cohort is the one in gray, and the idiopathic autism group is in blue. So what's interesting is that repetitive behaviors in our cohort were not as prominent as those for the autism group. And that's interesting because it raises the question, is part of the issue that families may not be maybe reporting what they think is the expectation for this syndrome? Are they potentially underreporting? But it's an interesting question and something actually that we've seen in some other genetic NDDs as well. Next slide. And here are all the repetitive behavior scores, domain scores, stratified by genotype. And again, the takeaway from this slide is that there are no major differences in repetitive behavior scores when we stratified by genotype. Again, with the same caveat that I mentioned, that the number of those who of individuals we analyzed for this analysis so far has been small, and this interpretation may change. Next slide. We looked at other types of maladaptive behaviors using an instrument called the ABC, which consists of a number of items and has subscales pertaining to irritability, lethargy, which is more depressive type symptoms, stereotypy, hyperactivity, and excessive speech. Next slide. And overall, the ABC showed that in our cohort, there was elevated levels of irritability, lethargy, stereotypy, and hyperactivity in our cohort. Next slide. And again, similar theme where we stratified these aberrant behavior checklist scores by genotype, and again, found no major differences based on genotype. Same caveats as before. Next slide. In terms of sleep, we used an instrument that I mentioned called the Modified Simons and Paraga Sleep Questionnaire, which has a number of different items and has domain scores pertaining to things like bedtime resistance, sleep onset difficulties, sleep anxiety, night wakenings, and other features. Next slide. And what this graph shows is the percentage of participants who responded to specific items from the sleep instrument pertaining to frequency of nighttime awakenings. And what you can see is that 66% reported daily or multiple times a week nighttime awakenings, which is striking. And in the part below, you can see the frequency of those waking up in the morning before 5 a.m. and staying awake. And that frequency is about 20% or so who do so on a daily basis or multiple times a week, which again is a huge number. Next slide. We looked at the Modified Simons-Paraga Sleep Questionnaire scores stratified by genotype. Again, similar sort of theme emerging where we don't see any major differences yet so far with each of these scores when we stratify by genotype. Again, things may change with updated analysis. Next slide. So what we wanted to see, and I think maybe some of the color doesn't show up, but what we wanted to see is how do sleep scores compare to behavioral scores. So first, what we did is we looked at the total sleep score, where higher sleep scores correspond to more impacted sleep. So we looked at total sleep scores versus each of the Vineland standard scores. So Vineland, again, is an assessment of self-help skills and has different domains. Again, there are no clear-cut trends when we looked at total sleep scores versus adaptive behavior scores. Next slide. But here's where things get interesting. So when we looked at total sleep scores versus repetitive behavior scores, we found this potential correlation with worsening repetitive behaviors and worsening sleep. And next slide here. And we also correlated total sleep scores with different domains on the aberrant behavior checklist. And again, similar, there's a trend emerging where for all of the aberrant behavior checklist scores, except for excessive speech, you were seeing this positive correlation between worsening sleep and worsening behavioral scores based on the ABC, which is a very interesting observation. But again, it also raises the question, what is leading to what? So next, all of this also points to the question, so what does the biometric data show? And so to give you an idea, first of all, what this data looks like, this is actual data from one of the participants in our study showing sleep staging, heart rate activity, physical activity over a several day period. Next slide. And more specifically, I want to talk about, just give you two illustrative examples. One from a 32-year-old in our cohort. And just to walk you through the graph, so if you look at the graph on the left, each horizontal row represents a 24-hour period. And what this graph on the left is showing is that this person goes to sleep on average around 5:50 p.m., 6 p.m. or so, and wakes up on average 7 a.m., but there are several periods of sleep outside of this. Again, very atypical for age. Next slide. And in contrast, this is a recording from a 3-year-old in our cohort who goes to sleep on average around 9 p.m., but he wakes up on average around 3 to 4 a.m. with some nap periods outside of this. And on the right side, you can see average heart rate activity and a measure of heart rate variability over time. Generally speaking, higher heart rate variability suggests a stronger, more resilient nervous system, whereas lower heart rate variability suggests maybe more increased stress or more dominant sympathetic response. Next slide. In aggregate, so those were just snapshots from individuals, but I wanted to show you the aggregate data. And so in the aggregate data, we looked at some of the sleep metrics, but comparing to a neurotypical cohort. And on the left, you can see the percentage of sleep that is REM sleep, and that percentage is lower in Kleefstra syndrome. So REM sleep is important for many, many important things, but including memory consolidation, mental processing, emotional processing. The right-hand graph shows wake after sleep onset, and this refers to the amount of time that somebody spends awake after initially falling asleep. And again, this value is higher in Kleefstra syndrome compared to a typically developing population. And overall, this data points to the fact that sleep maintenance difficulties in Kleefstra syndrome are common, and they're concordant with data that's been presented and published previously. So next slide. And these are all very, very interesting, but keep in mind that this is, cross-sectional data, and we're very much interested in longitudinal data. How do these profiles of neurobehavioral functioning, of sleep disruption, how do these profiles, change over time? And so I'm going to hand it back over to Zoe just to close out our talk and talk about some of our efforts to characterize the longitudinal profile, especially in young kids.
Thank you, Dr. Sid. So as Dr. Sid mentioned, we have one more research protocol that we're currently enrolling for, and the aim is to collect longitudinal natural history data to complement the data that Joost and Dr. Kleefstra's team collected several years ago. So as an overview, the action protocol is a 3-year natural history study in which Kleefstra syndrome is one of the cohorts. So this is co-funded by iDefine and also our department at Boston Children's, and it aims to enroll 30 individuals with Kleefstra syndrome between the ages of 2 to 21. And really the aim of this study is to contribute further to the natural history data that's been collected. We really need to better understand the symptoms, the genetics, and the natural progression of Kleefstra syndrome. We also really need to define biomarkers and endpoints for future interventional trials. So here I'm showing a tool that we use in our department called Gene Target, and it's used to assess if a condition is well poised to start a clinical trial, to get to that clinical trial readiness point that on that giant roadmap. And our department, we've scored a lot of different neurodevelopmental conditions, including EHMT1, to understand where on this, like what is missing, what do we have, and then what are ways that we can further develop ourselves and make ourselves more poised for a clinical trial. So when we did the analysis for EHMT1, we're actually in great shape. We've got a lot of things going for us, and we've done a lot of, there's been a lot of different initiatives. So we have a lot of these tools in place already, but there are two areas that we really do need to further develop. One is the natural history data. So we really need to better understand how does Kleefstra syndrome naturally progress over time, because that creates a baseline. So if we approach a pharmaceutical company and say, hey, we have a drug, we would like to see how effective it is in our patient population, they need to know what the baseline is. They need to know, once we give this drug, how does that change the natural progression of this condition? And then we also need to identify clinical endpoints for Kleefstra syndrome. So we need to find these measurable Kleefstra-specific features that we can measure when we give a drug. We have to be able to measure if we give this therapy, will X change? And will it change in a positive way? So in order to enroll in this action initiative, your child has to be diagnosed with Kleefstra syndrome. They can be male or female between the ages of 2 and 21. Families should commit to attending one annual visit over the course of 3 years, so one visit a year for 3 years. And parents need to be able to participate in neuropsychological and neurobehavioral assessments, and also be comfortable sharing a release form for us to look at any outside medical records. So thinking about the required components for this study, again, it's a mixture of different assessments. So we do a parent packet that we send before the visit. That's just online at-home questionnaires. There's a study with a BCH physician, Dr. Chari, who I showed in an earlier slide. There are parent and caregiver interviews, as well as neurobehavioral assessments directly with the child that has Kleefstra syndrome. And then we collect outside medical records. Optional components involve providing a blood sample at each visit. That's for in-person visits only. Additionally, there's the option to do a research EEG. This is different from a clinical EEG. So although both assessments measure brain waves, the research EEG looks for different signals. And also the cap is like a soapy cap. It doesn't have glue. So it comes right off and it smells like shampoo. And then there's also the option to do 1 week of Fitbit data collection, which is building upon the infrastructure that we developed for the circadian biology of HMT1. We'd like to further study sleep in this context. And then another optional component is providing photographs of your child's face and hands. So enrollment is still open. So if you are interested, I'll provide our email at the end of this presentation. But to date, 21 of the 30 slots have been filled. So thank you so far for the 21 participants that have enrolled, and for anyone who's reached out with interest. So in conclusion, I'd like to wrap up this talk by, highlighting how everything has built on top of each other to really get us to the point where we're getting there. We're getting close, and we really have that goal of being clinical trial ready in mind. So for example, our clinical findings by looking at our patient cohort and receiving community feedback, by people contacting us, meeting people in clinic, the disease concept model have informed, and also feedback from iDefine. These have all informed our research goals and our trajectory, and tools that we've developed in our studies like the Fitbit has helped advance our understanding of how EHMT1 functions. But all of this would have been impossible without the involvement of the Kleefstra community. And so together we're still working towards putting together these last few parts that we think will really set us up for success when it's time to test a targetable drug. So thank you to everyone who has helped us so far, has expressed interest, and we couldn't have done any of this without you all. So really thank you to you. This is a reflection, although we're excited by how much we've done, this is a reflection on how much you all have accomplished as well. So thank you. Oh, and this is our email address. So if there's any questions about the study, feel free to email us there. If you want to learn more about our clinic, that's also a great place to connect with us. So feel free to reach out to us at Kleefstra Syndrome Clinic at children's.harvard.edu.
Yeah, and Zoe, Jeff just put it into the chat as well, so folks can click on that link to get the email address and send an email right to you. We had one comment that I wanted to send to both of you, and I think it really highlights the reality on the ground for families around sleep. So someone commented, "I would do anything to get my daughter to sleep. She literally is up 90% of the night." So I don't know, Sid or Zoe, if you'd like to comment or have any suggestions for that person.
Yeah, I hear you. I hear that. And I think my heart goes out to you that sleep is so fundamental to everybody, to their child's quality of life, to the family's quality of life. There's a lot of different factors that can go into why somebody isn't sleeping throughout the whole night. Sometimes there's medical factors such as restless leg syndrome that can be evaluated for with the blood test. Sometimes we'll check a level of a chemical called ferritin, and if it's low, we'll supplement with iron. Sometimes there's other factors like pain or reflux that may be contributing. Assuming there's not a medication or medical factor, assuming that there's not something about the sleep environment or sleep hygiene that's playing a role. We think about different types of sleep medications that go from order from less likely to have side effects to more likely to have side effects. But maybe the best thing is you can email us, and we're happy to talk to maybe your clinicians and give some guidance about that.
Yeah, so Rebecca, who made that comment, you've got the contact point for the clinic, so you can always email the clinic, get your doctor in touch with Dr. Sid, and they can have a chat, which is one of the functions of the clinic to help doctors. I don't see any other questions. I did just want to thank both of you. It's really exciting to see this data that you're assembling coming out. And I had a question I did have one question, since there aren't any others, about you had shown data that showed that in cases where there are deletions versus pathogenic variants, there was a difference in ambulation, that there definitely was an association where with deletions or larger genetic changes, there was a reduction in the rate of ambulation or a later age. But it seemed like in a lot of the other measures, in the developmental measures, you weren't seeing, at least at this point, I know it's early days, but you weren't seeing as much of a difference. Did you want to comment on why it might be that in some areas there's definitely a difference, and then in others it seems like maybe there isn't so much of a difference?
Right. It's interesting. I think that question really pertained to, the functional motor milestone of ambulation. Is my child or is my family member, walking or not? And motor, I think the other measures that I showed don't quite capture that functional motor, that type of kind of functional motor assessment. And they're different domains. And, one would think that they should track, but maybe there's something more nuanced about that. So I think the short answer is I think that question about ambulation is very specific. The other types of instruments and data we presented don't necessarily capture that same information. You would expect there would be a correlation, but there's not quite. So it's a good question, and it's something that we should look more into.
Yeah, definitely an area we need to learn more. Okay, thank you so much again. And thanks for being such great partners with us over the years.